Good afternoon to everybody. My name is Sharda Agarwal, and I am the co-founder of Sepalika. As most of you would know and would be familiar with us, Sepalika is a natural fertility clinic, and we work with couples to improve their basic foundational health so that they can have children without the assistance of reproductive techniques like IUI and IVF. And I've been speaking, I literally speak to women every day, women who have fertility issues. And two big things I noticed, which has led us to do this webinar. By the way, we do this webinar every month. It's a knowledge webinar. And one of our goals is to spread information about how couples can try for natural pregnancy without having to resort to an IUI or an IVF. So one of the two big things that I noticed over the last few sessions that I've been having with women is, first, the moment a woman crosses 32 or 33, she's been told by her, her doctor, one of the first things she's been told is that the ovarian reserve is going to be dropping. So I would suggest you don't waste any time and head off for an IVF. The other case where I've noticed that patients are being recommended IVF is when they've been trying for a year, nothing has happened, and they go and visit the gynecologist or their fertility doctor. Once again, reports seem to be normal, but once again, they are asked to try or recommended IVF or IUI as their solution. And why this concerns me, not that we have anything specifically against IVF, but what this concerns us is that in our experience over the last couple of years, we've seen
excuse me, Sharda ma'am, you're on mute.
Sorry, have I been on mute all along?
30 seconds, I guess.
Okay. Just a couple more seconds, yeah.
All right, okay, sorry. So what I was saying is, and the reason why we want to do this session is because we've seen that over the last couple of years, women who've gone through multiple rounds of IVF or IUI, women who've even crossed the age of 35, have come to us, and we work with them to help them work on their foundation health to lead to a natural pregnancy. So with that little bit of introduction, I'm going to introduce our speaker for this afternoon, who is my co-founder, Mahesh Jayaraman. He's literally, as far as I know, and I know I am going to be biased, but it isn't. It is a fact that literally a walking, talking encyclopedia on fertility. Not just natural fertility, but understanding the entire physiology, understanding...
Sharda, you are not being biased. I can vouch for that. He is the walking, talking encyclopedia.
Thank you, Dr. Preeti. Thank you so much. Yes. So Mahesh Jayaraman has not just a natural fertility expert, but he has qualified in advanced blood chemistry analysis. Specifically, we studied in the area of fertility. He's qualified in nutrition, and I am not going to waste much time, but ask Mahesh to speak on this topic. The way we structure it is, Mahesh will do a little bit of, he'll give his points, a little bit of speech on this particular subject, but we're going to spend bulk of the time answering your questions. So when the question answer session comes, please either unmute yourselves, or you can put it in the message box or the chat box, and I will ask Mahesh that question. Over to you, Mahesh.
Thanks so much, Sharda. Thank you. And thanks to all my, medical colleagues who are here. Thanks, Dr. Preeti, for that kind interjection. And of course, Dr. Karishma, Dr. Arzu. We sort of, meet regularly as part of a group of functional medicinal practitioners, people who are interested in trying to look at the human body as a whole. So not just, trying to do something where you look only at the reproductive system or only at the endocrine system and so on, but look at the human being as a totality of the entire sort of health of that person. And that's basically the context for today's session as well. So
Mahesh, I'm so sorry. I did forget to mention that this session is being recorded with everybody's permission. I should have mentioned it at the start. But the reason why we're recording it is because this is purely educational in nature. Once this is done, we will share this video on our YouTube platform. And if any of you would like a recording, we will share it with you as well. That's the only reason why we are doing this recording. Sorry, Mahesh, over to you.
Absolutely. And to everybody who's participating, like Sharda said, the primary reason for doing this session is to take questions. Feel free to ask the questions anonymously if you so wish. Put it in the chat box and one of our team members will voice it for you. We won't take names if you don't want us to take names. So absolutely fine either which way. So the idea is, coming back to what we were just saying, the idea is when we take a functional medicine approach to something, it means that we are trying to look at the person as a whole. So even though a person may have a problem in the reproductive system, they've been told they're infertile for some reason, they've been trying for a while, they haven't really had success, etc. Today's world, unfortunately, because of lack of time, we're also rushed for everything, and because of the availability of resources. There was a time when IVF used to be at least 10 lakhs per round in the early days of IVF, when obviously it was only available to a few people. Nowadays, is at somewhere around a lakh at a starting price, going up to about 2 lakhs, depending on what part of the country, the complexity of the procedures, you can get an IVF round done. So because of increasing affluence among all of us, as well as feeling rushed, and there is unfortunately also a small amount of commercialization, to put it mildly, where people are being pushed into IVF. So our whole approach is first to ask, does a person who may have failed to conceive naturally within 6 months or 1 year, even if they are 30 plus, 32 plus, 35 even, is it that IVF is their only option? Why is it that there is nothing in between? From the time when you try, and there's so much confusion around when you should try, when should you time intercourse, Dr. Google tells you one thing, somebody else, your friends tell you a second thing, somebody else tells you a third thing. From that whole confusion to IVF, we've seen couples go that journey within 6 months. And we feel that there is too much that is not done between trying yourself without doing anything else to optimize your health and directly ending up with IVF. So that is the space that Sepalika is here to fill. That's the gap that we identified. So we began working with women who had PCOD, and several of these women had problems with ovulation and naturally with falling pregnant. But when we worked on their foundations and fixed everything from their digestion to their thyroid, to their sleep, to their stress, we found that they naturally conceived and went on to become mothers. And that's when we realized the extent to which the IVF industry may be what should be an absolute last resort is becoming a port of almost second call. You just try first for a few months, and if it doesn't happen, you end up with IVF. So this entire in-between journey of even asking yourself, why is my reproductive system not functioning properly? That has gone. And instead, we are ready to immediately jump to hormones, highly invasive treatments, things that can leave a lasting mark on the lady. And again, I keep pointing this out to every couple that we do any kind of counseling call with. We always tell them, have you asked or Googled to find out what is the success rate of IVF? Just 2 weeks back, I was at a very big IVF conference in Pune. This was held by Sunanda IVF Academy, one of the premier IVF teaching centers in the country. And there were more than 200 MDs in that conference room. And the only message that kept coming back from the senior speakers on the dais is success rates of IUI are as low as 15% in reality. So 15% success rate in an IU round means you need 7 rounds of IUI before you can get a successful pregnancy. And the guidelines themselves say that more than 5 rounds of IUI doesn't make sense. You'll have to move to IVF once you haven't succeeded after doing all the right checks in 5 rounds of IUI. When it comes to IVF, they're saying success rates can be higher than IUI. So how much is the higher? Again, it's only 30%. And 30% is for a 26 to 28-year-old lady. And by the time you reach the people who really need the IVF, closer to 32 to 35, the rate again drops to 15%. So 15% success possibility per round of IVF, each round of IVF costing you between a lakh and a lakh and a half, and the amount of hormones that are getting pumped in, etc. I am not here to say IVF doesn't have a rightful place. IVF has its place for people who have certain structural issues have taken a call to, maybe have a family at the age of 38 or 40, or are born with certain genetic defects that don't let them ovulate. They have serious medical issues. For them, IUI, IVF, etc., is a perfectly valid method. We are not here to say, go back to the, what shall I say, the Stone Age and say all science is nonsense. That is not what this is about. This is about saying, what about the in-between gap? Have you at least made your foundations right so that your body may be able to naturally produce a child? And that question is what nobody is asking or answering. So the way that Sepalika works, we help people with diet, with dietary supplements. We help them with Ayurvedic home remedies, with stress management, and with acupressure. And when we do this, we find that once we have aligned the lady and the gentleman along with nature, just give them give their bodies the right raw materials that it needs, many times the reproductive system will respond by itself. So that's my introduction. That's the reason we exist. Happy to take questions. Sharda, back to you.
Thanks, Mahesh. I have a first question. Somebody has messaged. The lady says that she's 36 years old. My AMH is 1.3, which my doctor has said is low. And she said that her doctor's advising her to do IVF. What would be your perspective on this?
No, so we don't consider, number one, we don't consider AMH as the only value that you should look at. That is the most important takeaway. We also know that there is an ideal 2.2 to 4, which is the range for AMH, in which a person can optimally expect to fall pregnant naturally. However, even when AMH is lower than that 2.2 number, what you should really be looking at is antral follicle count as well. So don't go by AMH alone. AMH, as many of our people who are joined are probably interested, so they may be aware, the term AMH stands for anti-Müllerian hormone. AMH is basically considered to be an indicator of how many more eggs you have left in your ovaries, just speaking in layman's terms. So when it is on the lower side, it is assumed that the number of ovaries left which you can produce, follicles left from which you can produce eggs is fewer in number. However, we have had many women conceive at AMHs between 0.4 to 1. Last one is 38-year-old with 0.8 AMH. She's in her 3rd trimester now. So it's not that AMH alone can be a good marker, which can be the final decider for whether you need IVF. Of course, since we don't have the remaining details, it would be wrong to say that the gynac is wrong, etc. Maybe there are blocked fallopian tubes. Maybe the antral follicle count is not sufficient. So we need a little bit more data, but just going by 1.3, 1.6 AMH is not a deal breaker for needing to immediately resort to IVF.
Thanks, Mahesh. For those of you who have just joined in, just a quick recap. We are doing this session addressing your questions on whether you need to do an IVF at all, or how can you avoid an IVF and look at a natural pregnancy. So you can raise your hand or you can type your questions into the chat box if you would like to maintain your confidentiality, and I will ask Mahesh. Mahesh is a co-founder of Sepalika along with myself. I have I have Lalita Salonke, who's raised her hand. Can you just unmute yourself, please, and ask your question? Lalita, you're there? Okay, so we will wait till Lalita comes in. Before that, I have other questions, Mahesh. What are the basic parameters, Prashanti has asked, what are the basic parameters which need to be optimized before a lady plans for IVF?
Excellent question, So not just for IVF. So I would say, before going in for any kind of fertility efforts, just make sure that your foundational health is first in place. And, sometimes a picture can speak 1,000 words. So Sharda, I'm going to quickly, use one of the slides that we often use during our counseling calls. And this is a way in which we are able to show people literally what is it, what it takes to be able to optimize something before you try for an IUI or IVF. Just give me a minute while I pull it up. I'm afraid for some reason it's not. I don't think I'm able to pull up the image. Just give me 1 minute, please. Thanks everybody for your patience. I'm just trying to pull up a PowerPoint slide, but if I can't, I'll just speak through it anyway. Maybe I'll come back to the slide. There it is. It is showing it now. I hope you can see my screen now. So you see, this is basically what we tell people that, all of your gynecological experts, including your IVF experts, are all working on that 5th floor of reproduction. There are 4 floors below that, and these are the ones to optimize before you go in for natural fertility or for IVF. The ground floor, the first basic thing to optimize is your macronutrients. Do you have enough proteins and fats in your diet? Most Indians tend to be carb-led, and even the few who do understand proteins either take synthetic proteins or they're taking it without taking the fats. That's flow number 1. Flow number 2 above that is the vitamins and minerals. Not having enough of D3, B12, zinc, iron, all of these can impact the higher flows. The third one is the thyroid, which is the master gland. We've had so many cases where women have come to us with multiple failed IVF rounds, and when we optimize the thyroid function, the body is able to multiply the cells of the fetus. The multi-cell multiplication is a very energy intensive process, and not having optimal thyroid can seriously impact this. 4th floor, which again is so difficult to work on, and yet nobody works on it. Maybe it's because it's so difficult, is that when you are under a lot of stress, your body naturally knows that you are in a fight or flight situation, so it does not let you reproduce. So looking at blood values like AM cortisol, your HSCRP, which are inflammatory markers that are conveying to your brain that you are under a lot of stress, this is not a good time to reproduce. Those markers have to be identified, and we help you to reduce your stress and everything. And that's when finally reproduction can take place. So to answer Prashanti's question, anybody who fixes these 4 floors, usually we find that the 5th floor literally fixes itself. There's nothing else that we need to do.
All right. The next question is, what are the basic tests to check if we are ready?
Okay. So ready for what?
I presume ready for pregnancy.
Okay. So, the minimum test that we have everybody do is the vitamins and minerals. So D3, B12, zinc, iron, etc. These micronutrients we can test for. Test for your fasting blood sugar, your fasting insulin. Many people don't realize that when you have a fasting insulin that is upwards of 5, even more so beyond 10, you will have insulin resistance, which in turn hampers ovulation. When you don't have ovulation, you cannot really fall pregnant. So fasting blood sugar, fasting insulin is the second thing we would look at. Look at the protein markers. Look at your total serum protein. Look at blood urea nitrogen. Look at creatinine. I know all of these may be too much for a person to do by themselves, which is why we offer what we call a counseling consult, where for a nominal fee, we go through all your reports and tell you what's wrong and what we find is out of balance. But some of these blood tests are good to do before you choose to go down the path of fertility. Of course, follicular, there are, again, factors which could be purely in the reproductive system. I'm not getting into those because I'm sure the OBGYNs and the gynacs are going to be talking about that.
Great. Thanks, Mahesh. The next question, and just to tell everybody, in case you want to keep the question confidential and private, please send me a direct message. I'm just reading it off from here. My husband's sperm count is very low, as also is motility. He's 42 years old. Can we conceive naturally?
Absolutely. So the question that arises is, why is the sperm count low? So generally, when we look at male factor, we look at immediately bifurcating why sperm count could be low into 2 factors. One is called obstructive azoospermia, and the other is called non-obstructive azoospermia. The term azoospermia simply means not enough live sperm, right? That's all that fancy term means. Obstructive means that they could be making enough sperm in their body, but it's not coming out in the ejaculate. This could happen due to a retrograde sperm flow. It could happen due to a varicocele. These are certain obstructions in the flow of sperm from inside the body to outside. Is any of that happening? We need to look at that. And then, of course, if that is not the case, then look at the other health parameters. The same 4 floors that I showed you work for a man as well. So if you just Google low D3 and poor sperm quality, you will get at least 10 studies on the first page itself that tell you how low levels of vitamin D3 can affect sperm quality negatively. That itself should tell you there could be many factors in vitamins, minerals in your foundational health that could be affecting the sperm. Improve those, and there's every chance that you should be able to conceive naturally.
What in the related question, what should be a normal or healthy sperm count? And I know you mentioned how to increase it naturally, but what could be a ballpark number?
No, so in our practice, we look at any, so total sperm count around 15 million. Within that, again, we look for progressive motility. So there are 3 parameters that we look at in a normal sperm test. There is count, there is motility, and there is morphology. Count should be above 15 million. Motility, we look for total motility in excess of 55, out of which rapid progressive, we look for above 30. When it comes to the morphology, anything above 4% of normal forms, that is sperm that has head, body and tail, all 3 intact, that should be above 4% in terms of total number of sperm. Those are the parameters.
Thanks, Mahesh. The next question is, I've had 3 miscarriages in all at 2 to 2.5 months. And the lady says, all reports seem to be normal and I'm 31 years old.
Okay. No, that's very, very unfortunate. Sorry to hear that. Repeated miscarriages are an important specialty. So for example, in Stanford Hospital, there is a separate department of repeated pregnancy loss. It's called RPL. And repeated pregnancy losses are a subspecialty. And Stanford literally has 10 kinds of doctors in that committee. Everybody from endocrinologists to genetic experts to metabolic experts and so on. So repeated pregnancy losses, especially when it is past the 2.5 month mark, that means we are past the 8th week, which means you've already seen a heartbeat. Not only is there a yolk sac, there is a heartbeat. So you've had a heartbeat, and post heartbeat, there is a failure of the pregnancy. Now, this is a very special case and needs to be looked into. First of all, if you've had 3 of these happen to you, I hope that at least once the product of gestation, or POG, whatever embryo was formed, if a genetic analysis has been done of that material, that could tell us why these sorts of repeated miscarriages are happening. Meaning, is there a genetic factor due to which the baby is able to grow up to the 8th week, 9th week, but beyond, it's not able to progress beyond the 10th week or so? That is one important thing. Second thing is, in repeated miscarriages, you must look at overall health of the mother as well. Is the mother hypothyroid and nobody has detected it? Because again, this is a very energy intensive process, especially past that 12th week. Just this morning, we had a session among the doctors, and Dr. Karishma, Dr. Arzu were all part of this. And we were discussing how the baby does not have his or her own thyroid gland for the first 20 weeks of gestation. For the first 20 weeks, the baby is entirely relying on the mother's thyroid gland to supply all the thyroid needed for multiplication or growth. Was it that the mother did not have sufficient thyroid? We don't know. We need to look into that. So repeated pregnancy losses is a crucial. There are very many sort of, beyond these factors that could be possible. Sometimes hidden infections for which we do torch testing. We need to get into, I'm afraid there's only so much that one can explain on a general forum. I would request the person in question to kindly send us the reports, and we should be able to throw some more light for her once we have the reports.
Right. Okay. So we will answer all your questions. I'm just going in order. I also see some people have raised their hands. So, kindly bear with us. The next question is, I have endometriosis stage 4. I've undergone laparoscopic surgery for this. Done IVF last year and conceived in the first cycle and delivered my baby boy in September. The question is it possible to conceive naturally? and I'm 31, and one of my tube is tied.
Okay. No, so honestly, sorry, what was the age again?
31.
Okay, all right. So 31 isn't old enough for us to rule out a natural pregnancy the second time around. That said, if one of the tubes is already tied up and there is a history of endometriosis, there is a chance that the second tube, which we don't know the health of, is actually damaged. So what is important for us to understand is that in a lady who has endometriosis, this usually happens from a functional medicine perspective when the lady has too much of the hormone estrogen. When estrogen is too high, there is a possibility that some of the endometrial tissue or the blood that is normally shed from the uterus during a period, some of that can travel in the opposite direction through the fallopian tubes, and therefore in that process cause adhesions or sticky substances to form within the fallopian tube. If one fallopian tube is already damaged and if it's been tied up, it's likely due to a hydrosalpinx or an infection that was there in it. There is a likelihood that the second fallopian tube is damaged as well. So the first step would be to do a HSG test where they put in a liquid dye and see if the remaining tube is open or not. If the remaining tube is open, there is indeed a chance even at this age to conceive naturally, but you must know that your chances of conception are vastly reduced. We all know that, it is the ovary, there are two ovaries in a lady and two fallopian tubes that come out of the ovary into the common uterus. So given that mostly ovulation will happen in one side ovary once, and then probably in the next one, if not in the immediate next period, maybe the second period from there, an egg is released from the other ovary. So whichever one side has a tube that's tied up, that ovary literally we have to count out of the whole race. So it means that when the ovulation is taking place on the side that has an intact fallopian tube, we'll have to wait for natural conception there. That said, endometriosis, like I said, is an estrogen dominant condition, which means there could be most likely ovulation troubles in this lady. That's why she needed IVF in the first place. So fixing the ovaries so that the ovulation takes place, all of this is quite an involved process, but indeed, we've had people who have conceived with IVF the first time around and had a natural pregnancy the second time around. I can't claim any of them had one of the tubes tied. That's not true.
Okay, all right. So here's a lady who's gone through multiple rounds of IVF and has failed. Sorry, my questions have got, there are so many questions coming in that okay. So multiple IVF cycles have failed, one of which was a clinical pregnancy. Doctors told her because her ovarian reserve is low, because her egg quality is low, she's been advised to go for a donor egg. What would be our view?
How old is she, please?
34 and a half.
Okay, all right. So, indeed, if they have done an antral follicle count and multiple rounds of IVF have yielded poor quality eggs, then, I won't say the age factor is that high that you need to go for a donor egg because of the age. But again, my question would be, have the foundations been fixed? We've had people with multiple rounds of failed IVF where they were told that their egg quality is not good enough. So, naturally, as part of an IVF process, you're given follicle stimulating hormone related drugs from day 2 of your period cycle. The doctors are hoping to grow multiple eggs in your ovaries so that they can extract it and then create embryos from it in the lab. We've had people who have had multiple rounds of IVF that couldn't proceed beyond the egg retrieval process because nothing got fertilized in the lab because the egg quality was poor. But once we worked on the foundations, they were able to get far better quality eggs. So see, it's like this. The common sense answer, in many of this will sound a little repetitive. But remember that your eggs are also made from the same food that you eat. So if your food is fine, your vitamins and minerals are fine, your thyroid is fine, everything is going to improve in your health, including your eggs. And so therefore, it is only common sense to expect that once you fix the foundational flaws, there is a good chance that the eggs will improve. Finally, because she's only 34 years old, let's say she wastes 6 months. I'm calling it a waste, though it's not truly that. But let's say, because people come riding on a horse, at least, if not on a train or an aeroplane when they come to us. But let's say ki 6 months are wasted, right? Still, I would say you're going to emerge in better health and 34 years plus 6 months, right? Or if you're already 34 and a half, you're going to be 35. Donor embryo should work at that time as well. So there is no reason to not try with one's own biological material by giving the body the right raw materials needed to create that better reproductive tissue. Do that, make better eggs. And if it fails, you still have a donor egg. Where's the problem?
Yeah, absolutely, Mahesh. And I think this is a point that, we should reiterate, which is that one of the reasons why we strongly advocate for natural pregnancy, beyond the fact that this is what biologically we're meant to do, is that this whole thing about egg quality, which is the biggest, reason that's being put forward by IVF doctors, is that you can improve egg quality, you can work on your foundational health. And even when AMH is low, and we know that AMH cannot be addressed, there are, as I keep telling people, there are 100 factors that lead to a pregnancy. Okay, AMH is very important, but it is one of those 100. And very often we're working on the other 99. We're able to use those guys to overcome what AMH cannot, nobody can do with it. And that's why we advocate and we request you to try your best, work on your foundational health to improve egg and sperm quality, because those are the only two things really you need for a natural pregnancy. I'll move on. Shruti, would you like to unmute yourself? I can see that you've raised your hand and ask your question.
Yeah, actually, when we are planning for the baby, can we do heavy exercises daily?
Yeah, absolutely.
And is it folic acid necessary when we are planning for the baby to take?
Okay, so I'll take this in two parts. One is, can you exercise while you're trying for the baby? Certainly. And you mentioned the word heavy. Now that depends. The only people whom we advise not to do heavy exercises, people who are already underweight. Sometimes we get women with a BMI that is between, let's say, 18 to 21. They already have less nourishment than they need for their own bodies. Under this condition, when they do heavy exercise, it sends a signal to the brain that there is not enough nutrition or energy available for both the mother and child. It could lead to what is called sportsman's amenorrhea, which means you stop getting proper ovulation or periods because you're doing too heavy work without having sufficient nutrition. Other than that, everybody else can absolutely do whatever exercise suits them. Folic acid is a poor substitute for what you really need during pregnancy preparation. What you really need is called methylfolate. Methylfolate is basically nothing but folate, as the term folate means greenery. So what you get from spinach, what you get from all your leafy vegetables, that is folate. In the 1970s and 80s, when people could not get proper bioavailable forms of folate, this folic acid was invented as part of one of the outcomes of the Industrial Revolution. Folic acid still continues to be used in this country. It is a very poor substitute for true methylfolate. Every online retailer, including people like Amazon.com, you will find methylfolate. So please use methylfolate in preparing for a pregnancy rather than use folic acid. Having sufficient amounts of methylfolate will lead to the baby's brain growth being proper for proper follicular maturation as well as egg growth.
Okay. Thank you.
Thanks. The next question is, I have done laparoscopy, which is cannulation of the left fallopian tube. There is PCOS, gone through 2 cycles of IUI. I'm 33. What should be a recommendation? Should I wait before an IVF?
Yeah, so again, I would say this is the thing that, at that conference that I attended, the poor speakers who are all senior with 30 years plus experience of doing IVF themselves, people would say, I've done 2 rounds of IUI, both failed. What should I do next? And the answer is do 3 more rounds of IUI. This is what the traditional allopathic, advice is, because success rates are only 15%. If any one round, there is only a 15% success chance. Simple mathematics tells us we need between 7 to 8 rounds to succeed in IUI. That said, if you've had a cannulation of one of the fallopian tubes, it means that there was a blockage and they tried to repair it surgically. Now, this means that there is a possibility, again, it is rare for only one fallopian tube to get blocked or damaged. Fallopian tubes are extremely delicate structures. We keep telling our patients, think of your ovaries the size of almonds or walnuts, not almonds. Walnuts is more the size. So two thin tubes coming out of those walnuts, that is how delicate fallopian tubes are. So if one tube is scarred, there is a good possibility that the other tube may be scarred as well. Also, that no doubt IUI is a better option before escalating to an IVF. But after about 4 or 5 attempts with IUI, as long as the other tube is open, I would not stick with IUI. Again, my advice to everybody is, even though we call this webinar, not doing IVF, etc., and therefore the focus often falls on doing IUI or IVF. How many times should I do it? And the focus is there. I would still say improve your foundations. Even the chances of succeeding in your IUI rounds are greater. That would be the summary. Yeah.
Okay. Thanks, Mahesh. The next one is this lady is 40 years old and she's had a miscarriage at 38. The doctor suggested donor egg IVF after failed IUI because she's not ovulating anymore. And
Okay.
she's got a period after 4 months.
Okay. So again, some of these cases, especially those that are 40, closer to that sort of mark, it's very difficult to give an opinion, on the fly with only partial information. So the question would be, how high is the FSH? At the point at which your ovaries are not ovulating at all, is the FSH well over 25, right? So if FSH is over 25 and AMH is below 1, then the prognosis is not very good for using one's own eggs. This is again within the conventional allopathic scenario. I'm not saying that it can't happen with natural interventions. Again, I don't want to, one swallow doesn't make a summer, but we've just had a lady at 43 conceive after 16 failed rounds of IVF. She's conceived with natural efforts. It's still very early days. We are not even past the first trimester, so I don't want to claim, that it's worked, etc. But she came in with a similar situation. She said, my ovaries aren't working. The FSH was at 16. So it wasn't past 25, but it was still pretty high. Anything above 10, we start getting worried that maybe the ovaries have gotten too tired. She's entered perimenopause. That is not the case. It is possible to rejuvenate the health of the ovaries once the raw materials are all given. So again, I would say a donor embryo is a very serious emotional decision for any parent to say, I can't have a child with my own biological material is one of those, very difficult decisions to take. So I would say, please share more detailed reports. Once we look at a follicular study, we look at the blood work, the FSH, AMH, and a few other parameters, we will be able to advise you better, but don't lose hope. I would say, don't rush into a donor embryo yet.
I have a different question. This is somebody who's 32. She's unmarried. She wants to know how much time does she have to conceive naturally? Because as per her gynec's advice, she did take the AMH test. The AMH is a 3.03, and the gynac obviously says it's satisfactory. But she says, I didn't know about antral follicular count, which you mentioned earlier in this session. So she's saying, what other information should I be using to estimate what's the latest date by which I can get pregnant naturally?
Excellent question. I wish that there was, human beings also came with the expire by date, like, things that happen on a shelf, but I'm afraid we don't. That said, your question is perfectly valid. I'm asking you to consider multiple factors in order before taking an IVF decision. And you're saying, what are those multiple factors? So it's a perfectly valid question. So beyond the AMH, do look at an antral follicle count. This is done by an ultrasound, usually a transvaginal ultrasound, but a good gynecologist or radiologist will be able to look at your ovaries and tell you how many immature or antral follicles are present in any given cycle. So generally, if we find that there are, let's say, at least 5 to 8 antral follicles in each of these ovaries at that point when we are looking at it, that is a normal presentation. And no two women are alike. That said, again, I'm going to put in a caveat. Obviously, we are here saying, don't get scared into IVF. So I'm not trying to scare you. But the truth is the following. When we look at IVF data, when we Google for stuff, what are my chances of getting pregnant at the age of 32? What we don't realize is the answer that we get is all based on Caucasian people's data. White women are the primary source of data for Google to present results to you. What are your chances of getting pregnant at 32? At the IVF conference that I recently attended, all the doctors unilaterally agreed that a 32-year-old Indian woman is as good as a 36-year-old white woman. It's as if Indians age, when it comes to ovarian health, it's as if they age 4 years in advance. We still don't know why. We don't know if it's environmental factors, it's genetic, it's the amount of stressors that Indian women undergo because they have family responsibilities in addition to everything else. We don't know what the reason is, but at 32, they say that you're as good as a 36-year-old Caucasian woman. So if you are going to try and get some population-wide statistics that tell me how long should I wait, what is my fertility, etc., and you just want a very general answer, look for fertility rates of 36-year-old white women. That's probably going to give you a thumb rule. The question is, why wouldn't I look at a 32-year-old Indian woman and what is her predicted fertility? The unfortunate answer is that data is not available. Our government doesn't think it's worthwhile to sit and, find out fecundity rates of 32-year-olds as a general population. Therefore, it's difficult. That said, at an AMH of 3+, and once you do an antral follicle count, if you're getting regular periods, there is every good chance that you are naturally fertile, and that if you try naturally, optimize your foundations and try for between 6 months to a year, even at 33, you would not have lost anything great. It's not like your time has run out. Oh my God, I wish I had done IVF sooner. I wouldn't say that about any 32-year-old with an AMH of 3. You should give it some time.
My wife was detected with breast cancer 5 years ago, and the lymph was removed. Chemo and radiation was suggested, but not done. We've gone through natural treatment. Now we're 42. Can we try for a baby since we don't have a child?
So the gentleman is 42 or the lady is 42?
I think he means the lady is 42.
All right. No, 42 by itself is a late age. It's not an age where I would say it is easy to conceive at all. Even though 3 minutes ago I myself said, here's a lady who's conceived at 43, but it's one swallow doesn't make a summer. That is important. At 42, there is every chance that IVF may need to be resorted to. What is worse is if chemotherapy is done, even if lymph nodes are not removed, we are all aware that chemotherapy has impact on ovarian health as well. It does lead to a reduction of antral follicle count. It leads to atresia and so on. I hope I got the data right on that.
The other way around, Mahesh. Lymph nodes were removed, but chemo and radiation were not done.
Oh, okay. That's good then. If we had a very localized cancer and therefore only the lymph nodes that were affected were removed and she is cancer-free, it's wonderful that at least the chemotherapy side effects aren't there. But again, I'm sure you realize this is such a specific question that for me to give you hope as a 42-year-old of naturally conceiving, we'll need to have far more data. Is the lady still getting regular periods? What is her AMH level? What is her antral follicle count, etc.? This is important. Generally speaking, a breast cancer will always involve hyperestrogenemia or too much estrogen. While in general, this may be a bad thing, for a lady to preserve her fertility, this may actually be a good thing. Having sufficient estrogen at the age of 42 may be a good factor that might work in her favor. This is again provided she's not been put on anti-estrogen medicine like tamoxifen. Sometimes cancer doctors will only remove the lymph nodes, not give chemotherapy or radiation, but put the lady on an estrogen suppressing drug like tamoxifen. If that has happened, that will reduce her fertility. So too many factors. If you could kindly send the file, we'll be able to help you better.
Okay. This lady conceived, but she's 34 years old. She got a medical abortion done due to cardiac activity. Her AMH is low at 0.78. The antral follicular count is 4.6, and the doctors are suggesting IVF. What would you say?
Sorry, I sort of got stuck on the cardiac activity. Could you repeat the last part after that?
AMH is low at 0.78, and antral follicular count is 4.
Okay, all right. No, so if the antral follicle count has been done multiple times, again, we don't go with a single antral follicle count. We have seen so many times, and this is all our seniors, So again, at this IVF conference, Dr. Anil Gudi, who's one of the leading IVF experts in the private clinics in London, was mentioning very clearly, many times in ladies, doing an antral follicle count on day 2 or day 3 may give you a wrong impression of a low antral follicle count. Funnily enough, in the luteal phase, around day 27 or day 28, you may get a far higher antral follicle count in such people. So don't go by a single antral follicle count as a way of telling that you have low fertility. AMH of 0.7, again, yes, it is on the lower side, but we've had people conceive as low as 0.4. So I wouldn't be that worried about it. You said you've had a abortion that had to be done. I'm assuming the fetal activity didn't happen in the child. So no heartbeat was detected, due to which the pregnancy was not viable anymore and you had to have an abortion. So this again is similar to what I was saying to the earlier questioner, which is that if no heartbeat is detected around week 7, week 8 of a pregnancy, this is not unnatural at all. Nearly 30% of pregnancies don't make it after conception, don't make it past this 10th week stage. This is a known statistic. This is almost nature's way of making sure that if the child has a genetic defect, the child isn't carried to term and becomes a burden on you as well as on itself. So that is the reason why for the first 90 days in India, we don't tell anybody, including even close family other than parents, that you're pregnant. Because in those 90 days, nature itself is undergoing a process of deciding, is this child genetically sound or not? So many times when a pregnancy fails at around week 7 or week 10, people get extremely disheartened. What they should know is probably there was some genetic fault in the way in which that embryo was progressing. Had that pregnancy continued, you may have actually, ended up with a child with severe special needs, or a child who may not have lived for very long. So, don't lose heart from the lost pregnancy. As far as your antral follicle count is concerned, repeat it again a second time, closer towards the second half of the period cycle. You may find, so don't go with a single antral follicle count. Don't say I have only 3 antral follicles and oh my God, with AMH of 0.7, both are tallying, my fertility is gone. I would test AFC at least twice, if not thrice, in a lady who was on the younger side before deciding what is her true fertility.
Okay. The next question is, ladies 34 years old, gone through multiple cycles of IUI, IVF, all reports seem to be normal, and yet she hasn't had a baby. Any suggestion would be helpful.
So again, my suggestion to, again, very relevant question for a lot of people. So the quote unquote is normal, right? So we don't accept normal. So none of my doctor colleagues who are on this call, Dr. Karishma, Dr. Arzu, Dr. Preeti, none of us accept the printed value which is there in a lab report as normal. Because normal here does not mean optimal. Remember that allopathic normalcy values have been determined to try and identify who is a person with disease. It is not meant to identify who is a person healthy enough to have a child. So many times we get people, I'll give you an example. People come to us, let's say, with a D3 value, D3 value of 25. And they say, isn't this optimal? Because it says it's normal. It is within the optimal range. 15 to 30 is optimal range. Some places 30 to 50 is the normal range. We don't accept those. For us, we tell all our patients, vitamins, minerals, thyroid function doesn't need to be normal. It needs to be well above normal. When it is optimal, automatic conception happens. In the example I gave at the start of this talk, there was this lady's problem was her free T3 was at 2.7 or so. We said your free T3, even though it is within the printed normal range, it needs to be 3.2 to 3.5 at least. Without having that free T3, your cells cannot multiply. So you may either not conceive at all, or if you conceive, you may have repeated miscarriages because the cells are not getting the support they need to multiply. That is thyroid function. So I don't know what you have read as normal, And many conventional doctors, unfortunately, follow those printed values. So when, at counseling consult, we give a long list of things that we don't consider normal. People are often saying, how come my doctor doesn't know this? But that is because preventive medicine is very different from disease medicine. Trying to have a child, you must be in the preventive optimal space. That's what is needed.
Okay. The next two questions, both these ladies have been through repeated miscarriages. The first lady is 31, but all reports are normal, including DNA testing. The second lady has had, she's 30. She has a kid, a healthy kid, but subsequently has been through miscarriages, no heartbeat, fetal pole. They did find some fetal anomalies in the TI-FFA scan, right? And she's really worried, should she consider IVF? So 2 cases of miscarriage, one normal reports, the second one has had a baby, healthy pregnancy, and this one, second one has been repeated.
Okay, so I'll take the second one first, because again, it's a question that may be, valid of interest to a lot of people. So when you have a problem of a genetic anomaly that is clear in the TIFA scan, maybe product of gestation was checked in some of the earlier pregnancies, etc., IVF could indeed be a viable option from the point of view of saying, what does IVF do? In IVF, they will do genetic testing of the embryo before placing it in the mother's womb. So the pre-implantation genetic testing may help us avoid specific genetic reasons why the baby is not being carried to term, why it's having to be terminated, etc. So identifying any genetic problems in a known case of genetic issues, it's a good way, at least from an IVF perspective, you get to see what's in the embryo before you put it back. That said, again, my question is, are those genetic defects truly not correctable? And this is what conventional allopathy still believes, right? So we say, if somebody says, could this have been prevented? The answer is immediately, no, it cannot be prevented. It is genetic. It was there in your genes. Again, functional medicine doctors, including Dr. Mark Hyman, who's one of the founding fathers of functional medicine, always say, genes load the gun, but habits pull the trigger. So what is it in your genes that is such that your lifestyle cannot change it? Maybe you were not sleeping enough. Maybe you had too much stress. Maybe your D3 was insufficient. Maybe your thyroid was insufficient. So when you fix these foundational areas, will that genetic error still continue to happen? The answer is, if we go from a functional medicine perspective, certainly the chances of genetic normalcy are far greater when your own health is in fantastic shape. So doing an IVF will give you at least a diagnostic where you can put only a genetically well-selected embryo into the mother, but it still does not ensure that no genetic anomaly will happen during the gestation. You will still need to do the double marker test, probably the quadruple marker test, and get up to the point of amniocentesis where you will check for any anomalies. So the diagnostic part of IVF is not curative. It is only preventing you from putting in a known genetic defective embryo back. So to that extent, it is helpful. But if you want to work on your core health so that there is a possibility that the genetic material may become of a better quality, I would suggest that is a more holistic approach to that. The other questioner, Sharda, without the genetic test, what was it?
She's gone through repeated miscarriages, but all the reports are normal.
Yeah. So again,
including the DNA.
I understand, and I do appreciate that the product of gestation genetic testing was indeed done. But 2 things. Number one, repeated miscarriages, once it exceeds 3 in number, some doctors even say 2. So the repeated pregnancy loss special group in Stanford Hospital, once the number of miscarriages is past 2, because still 2 miscarriages, they believe it is nature's way of not allowing wrong pregnancies to continue. But once it is past the 2 mark, the kind of workup that we do is far more elaborate. It doesn't stop. And yes, DNA genetic testing is very advanced, but it's not limited to that. Was thyroid function tested? Where all the infectious diseases tests done for all of the torch possibilities. So toxoplasma, rubella, cytomegalovirus, herpes. These are infectious diseases that many Indians carry within themselves latently, and often testing is not done for those. And if you have a trouble there, that is a possibility. Second, genetic testing that was done, I hope it was done for the whole assay of genetic problems that are possible. Sometimes karyotyping is done, but fragile mental retardation gene number 1, FMR1, is not tested. So we need to look at what those genetic tests were, and we need to look at the health of the mother itself. Is there something lacking in the foundational health of the mother, due to which the mother is not able to give the child the nourishment that it needs for the heartbeat to continue, for cell multiplication, etc. So I would, again say, please share reports. We'll try and do our best to help you, wrap your head around the best answers for those.
Okay. Besides general health and lifestyle and diet management, are there any specific pills, I presume the lady means supplements, or foods that they should focus on while trying for a normal pregnancy? Because she says a lot of doctors prescribe folic acid, but anything else? She's 29 and had a history of PCOS. As far as diet is concerned, so that I let you focus on the supplements, I'm going to put Sepalika's phone number. I have just put it in the chat box. Anyone wanting general dietary guidelines, which is what I recommend for our clients who are on a natural fertility program, please WhatsApp me on this number. Someone from my team will send you the dietary guidelines. But Mahesh, would you like to speak on some specific supplements or micronutrients, I would say, that people should look at when trying to get pregnant?
Yeah, absolutely. So the D3, B12, etc. are no-brainers. And what I mean by that is the absolute foundation. So check your vitamin B12 levels. If it is less than 600 pg per ml, you certainly will do better with a good quality vitamin B12. Check your vitamin D3 levels. If it is under 50 ng per ml, you will again do well to, take a good quality vitamin D3. Other than this, with a history of PCOD, specific supplement that can help you is myo-inositol. So there are several brands of myo-inositol that you can find in the, any of the good stores, including Amazon. This will help to improve ovulation in ladies who have a history of PCOD. This would be a good sort of starting point for anybody. I would say look into these specifically. And of course, Cipalika's dietary foundation. The reason we made it the ground floor is if you eat the right foods, you probably don't need too many supplements on the next floor. So, yeah.
So because you mentioned D3 and B12, somebody said she's low on D3 and B12. She doesn't want to get pregnant immediately. Can she wait for 2 years for natural pregnancy? She's 31 years old with no history of PCOS or diabetes.
Yeah, so these are two separate questions. Indeed, address your D3 and B12 immediately. Don't wait for 2 years. Can you wait for 2 years to fall pregnant at the age of 31? By all means, provided, of course, there's no early onset. I mean, you're still getting regular periods, you're ovulating. In that case, I would say it's not like, the clock is running out for you, at least not from our perspective.
Even if embryo quality is good, why does IVF fail? And how do we track ovulation and maximize chances of conceiving?
Okay, so this is two separate questions. So the first one is, even with good embryo quality, why does IVF fail? The answer is hiding right there in the statistics of IVF. No doctor is going to put a bad quality embryo into a lady. So all the statistics of 15 to 30% success rate for IVF is for good quality embryos. There is no bad quality embryo that's getting put in, which is, allowed to skew the statistics. That's not the case. Why does it fail? It fails because it is in nature. We haven't yet cracked nature to the extent that we will take over all the parts of nature and somehow we will ensure that the baby has to be produced 100%. It's not there. There is a 70% failure rate in IVF in any given round because we are unable to mimic nature that well. This is the general answer. So always IVF will have low success rates, even low as in, as a normal human being. Just before coming onto this webinar, Sharda, just spoke to a couple and, we were having this chat and we were saying, oh my God, we have tried 2 rounds of IUI and it's not worked. And, so every human being thinks, Suna ki statistics, we've heard that the statistics are 15% success rate, but somehow we believe we are in that 15%. And each round, we believe we are in that 15%. This is human nature. We always look for the good news. We think the 85% is going to happen to somebody else. But how is that possible? If 10 of us are trying and 7 of us are going to fail, it's not going to be that you will always be in the lucky 3, right? So that is number 1. Number 2, if indeed everything was great, the question comes, what about the mother's health? Was the mother's thyroid optimized? And a second hormone that I want to speak about, I forgot to invite Dr. Vivek Kadambi, who is our progesterone guru and, senior to all of us. And he keeps saying lack of progesterone in the first trimester, both not testing progesterone levels, or even if it is tested, then the supplemental progesterone that is given is either dufestone or Sustain. And both of these are not as high quality progesterone as micronized progesterone. Truly micronized progesterone is pro-gestation. It protects the gestation or the pregnancy. So if you have an embryo transfer that has happened of a 5-day blastocyst, which is of good quality, implantation has taken place, check the progesterone levels on a monthly basis after that. In precious pregnancies, we often advise vaginal progesterone suppositories must be given under the supervision of a BHRT expert. BHRT stands for bioidentical hormone replacement therapy. So, having somebody like Dr. Kadambi in the picture, ensuring that the gynac is super optimizing progesterone during that first trimester can indeed improve results when it comes to, IVF. That said, when I look at large-scale Cochrane meta-studies of use of supplemental progesterone lead to better results in IVF pregnancies, I'm afraid population-wide data is not there. I still see that in individual cases, we do very well with it, but it's very difficult to tell people that, if you use progesterone, 100% everything is going to work out. We're not sure of that. But again, if you just go by the statistics and you say, at best, there is a 30% success rate, it means that IVF needs to be done for 3 rounds before you can say, I am especially unlucky.
Right.
If you're within 3 rounds, you're still within the average.
Okay. This lady, her periods have dropped to 2 days. She's 34 years old. Her AMH is at 0.6 and she's seeing this pattern. She said, I'm curious, can I conceive naturally?
Yes. And again, this is wonderful because lots of, not just Indian women all over the world immediately know when something is not okay with their periods. And the first things that women in their 30s will notice is scanty periods. That earlier I used to have flow of 3 days or 4 days. Now I have flow of 2 days. What does it indicating? So for this, we often tell people a little and you'll know how long you have left, etc. So from day 0 of your period, your brain starts secreting a hormone called follicle stimulating hormone, FSH, that speaks to your ovary and tells it to start maturing eggs. The maturing eggs start secreting a hormone called estrogen. And this estrogen is the one that builds up the inner wall of your uterus, the endometrium. If you finally don't have a baby in that period cycle, it is this inner wall of the uterus that is shed as period tissue. So if your bleed was 3 or 4 days, it meant that there was a healthier ovulation at the time when you used to have 3 or 4 days period. More number of eggs were maturing, more estrogen was being secreted, more inner wall was formed, and finally you had a period that lasted for 4 days. Now that you're seeing that it's only for 2 days, it means the inner wall of the uterus is not getting formed to a nice thick 8 mm plus. It's likely going to be a thinner endometrium that you're forming. That is because of lower estrogen secretion, which in turn is because of lower follicular activity. The ovaries seem to be gently going down in their function. Can it be improved? 100%. That's how nature works. So give it the right raw materials, and at this age, at least, certainly at just 31, there is every chance that your periods can again improve. It will first become 2.5 days, become 3 days, and you will see in the follicular studies, the ovulation improves. You can conceive naturally, most likely. All other things being equal, I should quickly caveat.
Excuse me. Sorry. I don't know how this works. I hope I'm not interrupting anyone.
No, please go ahead. Yeah, go ahead and ask your question.
Okay, I'm asking on behalf of my wife. She's inside right now. She's already about 42 years old. Never conceived before. We've never had a child before. Okay, and she was a cancer survivor also. Back in 2013, she had blood cancer. She survived through that, and she's fine now. Now, she has a problem that is inherited from her mother. Okay, they have very, very long periods. Okay, they have very long periods, like it can take even up to 10 days, 12 days, like that. Okay, and very, very irregular periods, spottings for a long time, and all these things. And because of that, many doctors, back even before I met her, and the doctors have already said that she can't conceive because of these irregular periods. It's very hard to track. And now, we are already 42, and but still, no kids and all. We are wondering, maybe can we just give this a try? Are there any? I'm sure that you all are very thorough at what you do, and I really respect that. But for us, is there any way for us at all?
Yeah, so again, really appreciate the question, and I empathize with what you guys must be going through. So women do inherit some of these characteristics from their parents, and especially prolonged periods and having irregular periods. This is part of a ovarian dysfunction that the woman can often inherit. Often there is also what we call estrogen dominance in such women. Relative estrogen dominance is what we call it. The answer is at 42, it's probably very difficult for us to give you a positive prognosis going forwards, because even if you came with none of these problems at 42, I would still say that there is a likelihood that the lady's fertility has declined substantially. So essentially, for us to give you any hope, we would really need to see the actual condition of her ovaries. So you must have heard with many women who are in their early 30s, 31, 32, even without seeing their reports, I'm giving them a positive message that most likely you should be able to conceive. Yes, wait for a year and so on. If I was just honest to the medicine that we practice at 42, I would have to see something surprisingly good about the ovarian health of your wife to be able to give you hope for natural conception. So I would say please send in your reports. We've got a simple process through which once the reports are in, once we have all the parameters, we're able to give you a sort of well thought of answer, not just give you useless hope or give you, discourage you unnecessarily. But yes, it does take special data because she's at such a, sort of extreme of age. So I'm not even going into the chemotherapy or into any of the effects that might have happened from the cancer treatment. I'm just going by age. Even if nothing else was there at 42, I would have said, please send reports, then we'll give you better answer.
Okay. So in this juncture, it's better that we take for ovarian to check the health of the ovary and all. You have got to see the blood test, isn't it?
That's true. That's true. So if you can, when you write in to us, I'm sure we'll put in email address or so on, right? Sharda, could you just?
I have just to tell you, I have spoken to your wife. So I get it because I recognize the name there, and I've shared the details already of the consult with her. So we do have our contact details, but I'm more than happy to send this again to you.
Yeah, please just see. I wasn't always here. I'm always usually going around work and this and that. So maybe it's my fault. I may not have. She has told me a few times. I may not have followed through properly, and I apologize for my.
No worries. We'll send it again to you.
I will definitely follow through with it, and I just my personal request to you is I hope that we just tell us. Whatever happens, whatever there is, just let us know. I can understand that, and because see, she wants to have a child, and I also want to. It's not that we are not against adopting anything, but I don't mind. I'll definitely adopt a couple of kids in the future. Okay, we can definitely do that. I just want a child, that from my wife, because she's very dear to.
Sure. No, we much appreciate your question. We really appreciate the fact that you spoke up and you shared with us. Thank you so much for that. And we will do our best. Of course, it is a natural instinct for every human being to want a child from their own biological material, from their own, a piece of them, as it were. So we'll do our best. We'll tell you honestly what we see medically, and all the best to you and your wife.
Thank you so much. Thank you so much. It means a lot.
Mahesh, the next question is for a lady who's got 2 periods in the same month. She's 34 years old. She says, otherwise, the cycle is normal, but of late, there's 2 periods in the month. She's wondering why that happened and will it affect the pregnancy chances?
Okay. So if this has just happened once, then, I would not worry about it too much. But the understanding, you just need to understand why 2 periods may happen within a given month itself. Generally, the way that people look at periods is people don't realize every missed period is a missed baby. Okay. Every time you get a period, there's a baby that you didn't have in that period. So it means actually your body and nature prepared everything that was necessary for you to have a baby. You chose not to have a baby in that cycle. And so finally a period happened. This is how we look at periods. So sometimes what can happen is in a period cycle in which there is some new stressor, you go on a trek or there's a huge amount of sometimes there's a death in the family or something extremely serious happens to somebody, you can end up, your body senses that this is not a good time for you to fall pregnant. May I request everybody to mute themselves? There's a little bit of yeah, thank you so much. So, every time your body preps for a period, it's actually prepping for a baby. So if you have a huge stressing event sometime in the middle of your period cycle, your body may decide this is not a good time for this lady to have a baby. So rather than release an egg and have ovulation and then wait 15 days for a period to happen, the body may choose to have what is called an anovulatory period. It means there is no ovulation that happens in that cycle. And so by day 15 or 17, you're getting the next period already happening. This is usually due to an ovulation or a progesterone deficiency, which can be temporary, like I said, due to a high stress event, physical or mental. But if it is happening repeatedly, you should see a good OBGYN and understand, are you getting ovulatory cycles or not? Do a follicular study or day 21 progesterone, and that will tell you, are you getting normal ovulatory periods or is it a trend that you're not ovulating?
Thanks. Can birth control pills affect fertility? Because condoms are not a very reliable source or method of contraception.
Yeah. So it's there in the name, right? What it does is it controls birth. So I wish that, they would give it a different name and not call it a birth control pill, but call it a birth chances reducing pill. So unfortunately, that is where it's at. Every time you take a birth control pill, unfortunately, you do reduce your chances of falling pregnant even in the future. This is the part again where pharma industry is not really being completely upfront. I don't blame them. They have a product to sell, so they're selling it. But that said, any study, just Google, we're all great at asking Dr. Google things. Just ask birth control pills reduces fertility after 3 years of use. You will find that even after 3 years of discontinuing birth control pills, there is still a lingering effect of lowered fertility that happens to a woman. This, there are enough and more studies on this. Unfortunately, it is not told by gynacs to many of the patients and clients who come to them. There is a certain lab value called SHBG, sex hormone binding globulin. Studies have found that if a woman regularly uses birth control periods for, let's say, 2 to 5 years, even 6 years after discontinuing, her SHBG values are higher. So her sex hormones get bound up more than in a lady who did not use birth control pills. So yes, birth control pills do cause side effect of lowering fertility, especially with longer term use. So if you are looking to fall pregnant, then it's probably not a good idea to use birth control pills as your method of contraception. We do appreciate that condoms are not 100% fail safe, but there are far more wise methods of doing it. There is something called the fertility awareness method, FAM, FAM. People often mistake fertility awareness method for an older method called calendar method. And calendar method used to have notorious failure rates. So somehow people who hear about FAM, they say, "Arey, calendar method, it doesn't work." It's not the calendar method. look up the fertility awareness method. When used in combination with a barrier method like a condom, very high rates of contraception can be achieved. 98 to 99% when used as trained, you can achieve contraception. So please look into that.
The next question, lady is 31 years old. Her right fallopian tube is blocked. Her endometrium size on the 10th day is 6.5 mm. 11th day is 7.7 mm. Husband's semen is 128 million. Can I conceive naturally?
Yep, you've given me all nothing but good news, except for the right fallopian tube that is blocked. Again, the question therefore is the left fallopian tube okay? Do we know from a HSG that this left fallopian tube is at least patent? Then there is indeed a 50% chance of natural conception during the times when the particular ovary which doesn't have a blocked fallopian tube, let's say the right fallopian tube is blocked, that means the left ovary, when it ovulates, if you do follicular studies with your gynecologist around that time, predict ovulation when it's going to happen, and just before ovulation onwards start trying, there is a chance that you will conceive. There is nothing wrong in the sperm count that you mentioned. Rest of it seems fine to me.
This lady is 36 years old, married for 13 years, never conceived even once. Every gynac has told her everything is normal with her. She tried IUI and IVF, both have failed. AMH is 1.07. Do I have to go for an IVF again?
Nope. As long as we are clear that what we consider normal, once I look at the reports and we are sure that, we don't feel that you are normal, that there is still room for improving foundational health, we may be able to, help you see things differently. At an AMH of 1.0, 1 point something, is IVF your only option? The answer is no. If all other reports are normal, it may be one of these foundational factors holding you back. We can check and let you know.
Okay, here's a question for the husband, from the husband rather for her husband. He's got type 2 diabetes. Sperm quality is low. He's 37, she's 34. She's had her first IVF cycle where one embryo transfer and one FET was done, but that's a failure. She's got another FET scheduled for October, trying for 6 years now. She's saying, should I go for the second IVF cycle in October?
Yeah, so it depends upon why finally you resorted for IVF. If the reason to resort to IVF was male factor, if the reason that, the sperm quality was poor, the sperm wasn't able to fertilize the egg naturally, and so we decided to do an IVF cycle, we have often found that diabetes also affects DNA factors. So I don't know what is the level at which we did testing, for this particular lady. So whenever we do sperm test, there is count, there is motility, there is morphology. Beyond that, there is a second level of sperm testing that is called a DNA fragmentation index, DFI test. So run a DNA fragmentation index on the sperm, check if the DNA damage of the sperm is high, which means that even when morphologically good-looking sperm are used in ICSI to fertilize the egg and form an embryo, the final embryo quality may still not be able to produce a viable pregnancy because the sperm factor may be the case. I don't know if the lady, there are some factors as well. Maybe the egg quality isn't good enough. I don't know why it is that, they've gone for the IVF procedure altogether. Having said that, your specific question is, should I go in for the FET of the frozen embryo transfer of the embryo that remains? Now that is if the factors why you're unable to carry the frozen embryo lie in the lady, if there are uterine factors, if progesterone is inadequate, if thyroid is inadequate, optimizing those will improve your chances that this particular frozen embryo transfer may lead to a success. That said, since the sperm and the egg are from before a time when anybody has optimized it, I don't know what is the quality of the embryo itself. If the embryo is not of a quality that it can lead to a viable pregnancy, then doing work with the mother alone may not do the trick. I know this is a very difficult decision. We've had a couple like that recently, where their health has improved so tremendously working with us over the last 3 months, because we do before tests and after tests. So insulin resistance parameters, thyroid parameters, vitamin parameters, everything has changed dramatically in 90 days. Now they're saying we have a frozen embryo from before the time we worked with you guys. Should we use that embryo for a transfer or not? And my answer is, it's a very difficult decision because at that time, neither the sperm nor the egg was properly optimized. Why don't you first try naturally now with the better quality egg and sperm? And if that fails, the embryo transfer is always there. Frozen embryo transfers can be held forever. The embryo is kept in a state of being frozen and in suspended animation. So you can opt for the transfer after natural attempts fail. What is the hurry to do it?
Here's an interesting question. How do you determine the fertility window or the best time to conceive? Because this lady has a period cycle of 35 to 40 days, not the typical 28-day cycle.
Yeah. So, if you are trying naturally, my suggestion, you have a 35 to 40-day cycle. We've had many women at Sepalika have long cycles and conceive only because we made them try at the right time. Okay, so it's important for you to try at the right time. Here's how we determine this, right? And this is a general thumb rule. First up, let me tell you, if you truly want to try with a greater chance, and a scientific data available should tell you when you should try for timed intercourse, then the best way to do this is to do a follicular study. When you do a transvaginal ultrasound with a qualified gynecologist from around day 5 of your cycle and watch the dominant follicle grow to a size of about 18 to 20 mm. That is the size at which a follicle ruptures and an egg is released. So if you see in a follicular study that follicle has reached the size of 18 mm, no matter what point of the cycle it does it. So in a lady with a 35-40 day cycle, I wouldn't expect an 18 mm sort of size to be reached before, let's say, day 21 of the cycle. So if you ask Dr. Google, it will tell you that around day 14 to day 16 is the right day to try for conception. That is because they are deducting 2 weeks from the total cycle. So if you have a 35-day cycle, then deduct 14 days from it. And around day 21 is likely when you will be, actually ovulating. So if that happens, then, that is the window for you. But if you want to try it more scientifically, beyond just a thumb rule of 2 weeks before expected onset date, then please do a follicular study. When the follicle reaches 18 mm, that's when you should start trying.
This lady has her tubes which are snake shaped as per histoscopy. AMH is 1.98. She does get periods, but she doesn't ovulate all the time. And her flow is less. She's 31 years old, has had unsuccessful IUI and IVF. Can she conceive naturally?
Okay, so the convoluted tubes shouldn't have in any way affected the IVF cycle. So all that happens is, normally the shape, I'll just, sometimes picture speaks 1,000 words, etc. Let me quickly, for the people who may not be aware of what it looks like, just show you what the normal physical structure is, right? So we can see on screen here, this is the normal structure. So this is your ovary, these 2 white things. The tubes that come out of it from both sides are these, and then they go into the uterus. Now this lady has convoluted tubes by birth. So this particular tube, than being in a nice sort of C shape, it's actually probably convoluted in some way. When it comes to natural conception, when the sperm enters through the vaginal passage, you can see in my cursor, and it's supposed to meet, the egg is released from the ovary, egg travels to the middle of the fallopian tube, the sperm enters from here, it also travels to the middle of the fallopian tube, where an embryo is formed. This is where conception happens. So if it's a convoluted tube, either the egg which is released or the sperm which is trying to enter may not be able to meet. But in an IVF cycle, they have extracted the egg from here. They have taken the sperm separately into a petri dish where they have formed an embryo, and then they have put the embryo back into this place. So convoluted tubes have nothing to do with an IVF failure. They do have to do with an IUI failure, So the reason that the lady's IVF has failed is unlikely to be the convoluted tubes. We need to look at what is the other reasons. Are her foundational health factors fine, etc.? So that would be my answer.
Okay. Can azoospermia cases of varicocele patients at 33 years of age be cured?
Yes, they can be, and it depends upon the degree of the varicocele. Sometimes varicocele can be addressed through medication alone. At other times, varicocele needs a surgical intervention in order for it to be removed. But if the azoospermia is primarily coming from an obstructive varicocele that is happening, then indeed it is possible to correct it surgically. Azoospermia, even as long as the sperm is being formed inside the testicles, that is a different kind of azoospermia from a person who has a varicocele issue. What does it mean? If sperm is being formed inside the gentleman's testes, but when he tries to make a sperm donation at the lab in order for us to get a sperm count, no sperm is able to come out because the passage is obstructed. In that case, the sperm is still being formed within the testes, and either surgery can correct the passage, or in a worst case, there is a procedure called TESA, where the sperm is removed via injection from the testicles. Because the passage is blocked, you can still remove because sperm is being formed, it's just not coming out in the ejaculate. So the lab is still reporting azoospermia or zero sperm, but that is because the sperm is inside the body, it simply can't come out. So if you remove the sperms from the testicles, you can indeed conceive, but it is not, obviously this process is not possible through natural conception. In such cases, if surgery cannot correct the flow of the sperm, IVF is the only option. Even IUI does not work.
Okay, thank you. There's somebody who's raised their hand. I can't read the name, but it says Redmi Note 6 Pro. Would you like to unmute and ask your question?
Yes.
Go ahead, please.
Yeah, is my voice audible?
Yes, it is.
Is my voice audible? Yeah, this is Soumya here. Hello, everyone. I'm 37. I'm married since 2 years ago. So we are trying for natural conception. We have done all the tests. The AMH is 1.21, and his sperm is like count is like for 10 million per ml, and motility is 20, and morphology is some 40% or 20% exactly like that. So can we try for natural conception? One IUI has failed. It was like in a hurry we did. The egg has been ruptured. They said that we have to go for IUI. We did it, but it was more stress at that time. So now because of the age conception, they say that you can go for IVF. Is there any chance, because I don't have any PCOS, PCOD, no thyroid, and I don't have any other health issues. Periods are regular, like for 3 days. So can we try for natural conception, or we have to go for IVF? Because the more we are taking stress nowadays for natural conception too.
I understand. No, so, lots of couples find it very difficult. At 37, it's also not possible to try naturally. How many times are you going to try in the window? These things people don't realize are real world problems. Simply to ask a couple to try every day during the ovulation window, it's just ridiculous. It's not possible. You're not 20 anymore, So some of these issues indeed are there, but from what I can see, from what you're mentioning, certainly the gentleman's sperm needs to be optimized. Sperm health can improve. 10 million is not such a bad count. It's not like azoospermia where there is no count at all. 10, it needs to cross a 15 million mark. Certainly it can help. Motility can be improved. Morphology of 2030 is absolutely perfect. There's no problem. Morphology is a negative score. In morphology, when they report 4%, it means 4% is normal. 96% is abnormal. So if they are reporting 20 or 30, it means only 30% is abnormal. 70% is normal. So morphology is not an issue. But you have mentioned that, you, according to the reports that you have seen, you feel, for example, you may not have thyroid. But most likely you have only done TSH. Yeah, you've done TSH.
Yeah, we have done this. Yes.
Yeah, we don't count.
It's only like,
Yeah.
sorry?
So,
Sorry, I didn't get you.
sorry, you please go ahead. Tell me the numbers. What was your TSH?
It is 4.
Yeah.
4.
Okay. And what about T4?
T4 is also means whatever the test, I don't remember the
Yeah,
numbers
no problem.
because I'm on the call
So
now.
maybe,
Because as per the doctor said, I don't have any other issues. But the thing is, they only predict on the age and the quality of egg and his
okay.
sperm. These two only they talk about.
Okay. First of all, at a TSH of 4, the thyroid is not normal. Okay. So the
Okay.
doctor who says it is normal, they don't understand endocrinology. They understand reproductive
Okay.
medicine. So there is a problem there. So we don't allow any of our, ladies who are trying to conceive to have a TSH even over even 3. That is number one. Number two, TSH is not the right test. Maybe you joined a little late or didn't hear that part of the conversation, but we don't rely on TSH alone as a thyroid marker. We look for something called free T3. So unless you do a free T3 test, and free T3 is between 3 to 3.5, it is not normal thyroid, not enough thyroid for having a baby. It may be enough thyroid for you, but it's not enough surplus thyroid to create a baby. So many times people come to us saying all our tests are normal. So when we look into the tests, we point out that these are not normal, not enough to have a baby. So, that is another thing to consider. But I don't think age alone with an AMH of 1.21 is a good enough factor to say IVF is the only option. I wouldn't say that yet.
This couple, Mahesh, 3 abortions. The first 2 were in the first trimester. The last one was in the 6th month because the baby had many anomalies. They want to know whether he's 40, she's 37. They want to know, is IVF the only option or can they try it naturally?
Well, even if we tried naturally, certainly we'd have to do the double marker, the quad marker, probably even an amniocentesis to ensure that the new child who is being created has no genetic defects. But to begin with, again, I would say genetic defects that often come in the embryo are due to poor foundational health being at least a contributing factor. So both the father and the mother, if their health is super optimized in terms of foundational health, there is a chance of producing a better quality embryo. That said, with repeated abortions and with such an advanced abortion at even 6 months of gestation, it will be very important for us from the beginning to do lots of tests to diagnose. So we do the double marker, we do the quad marker, but we've again had cases like this in the past. We've had people with repeated genetic anomalies in the embryo, which were later able, at least for one conception, we were able to ensure that the child did not carry the same genetic material because the parents' genetics were itself improved.
Okay. And someone with multiple fibroids and high AMH of 10 at the age of 35 conceive naturally?
Yeah, so the AMH of 10 is not a problem. Just give me 1 second. Sorry, I had somebody trying to draw my attention. Okay, so the AMH of 10 is only tells us that likely the lady has a PCOD history. Okay, high AMH is usually shown in a PCOD history. We still need more data of FSH and LH along with this AMH of 10 to be able to tell, what needs to be done. What was the first part of the question? I'm sorry, I got distracted.
So high fibroids, multiple fibroids.
Multiple fibroids in our experience, again, this is a bit of a clinical call for the gynac on the ground to take, but fibroids per se do not stand in the way of pregnancies, either natural or IVF. The position of the fibroid is what matters more than the size of the fibroid. You may have multiple fibroids, but till they are not near the mouth of the uterus, not near the fundus, or they are not going to obstruct the baby from growing, there's enough space in the internal cavity for the baby to grow. Till that is there, you should not have a problem with fibroids. If at all, indeed, when we look at the reports, there are multiple large fibroids which are in delicate places. Still, after a surgery or a myomectomy, you can go for a pregnancy. That should not stand in your way. PCOD can lead to high AMH of 10. Once you begin improving the PCOD, the AMH can come down. Ovulation is possible. natural pregnancy also should be possible, all other factors being okay. We don't know about that.
Got it. Okay. So this lady says she thinks there's an intercourse issue between the couple, and she feels that maybe the sperm is not going inside properly. Since her periods are normal, all reports are normal, and yet she's not been, follicular studies are normal, and yet she's not been able to conceive. And she's consulted 4 gynacs already.
So usually in such cases, we do advise that the gentleman must also see a urologist, because, generally it's not just a vaginal passage issue, because if it is a vaginal passage issue, if you see 4 gynacs, surely somebody will notice if there is a problem of the opening itself. Is there some structural issue where the sperm is unable to reach inside the lady's uterus? If that is not happening, the chances could be, if the gentleman has an issue of erectile dysfunction or something where penetration is not taking place properly, it's important to get a urologist consult for the gentleman rather than keep worrying about the lady. Also, many times women, when they try timed intercourse, they somehow believe that if it doesn't happen, it must be because the sperm is not getting in. This is a natural common sense error that lots of women make. Again, I must point out, even for completely healthy couples, the chances of conception in any period, if you try for 4 periods, you may succeed in 1 period. This is for somebody who is of the perfect biological age, couple of 24 or 25 years of age, trying at the right time of the month, the chance of conception is 1 in 4. Many people don't realize that because we only hear good news from our friends that, hey, I conceived, they conceived. Nobody tells you how many times they didn't conceive. And that is the natural selection process. Human beings have a very high rejection rate. So if lots of times women may feel the reason I'm not conceiving is sperm is not reaching inside, but it may simply be that you haven't tried enough times or at the right time. So, look into that as well.
Yeah. Coincidentally, 3 women, all at 43. And the question is, can we conceive naturally, or is it too late to try?
At 43, certainly, even if we manage with a pregnancy, it will be a risky pregnancy. There is no question. All right. So again, my thing is, anything 40 and upwards, we're looking at a risky situation. And therefore, it is all about individual cases. A lady at 40 may still have a biological age of only 35 because she's lived a life which was about healthy food, great habits. When we look at her ovaries, when we look at her uterus, we may say this doesn't look like a 40-year-old person at all. So it will be very, very case-to-case basis. We do have women who conceive at 43. They need a lot of care during the 9 months of gestation. Progesterone levels have to be maintained high. We have to do double markers, quad markers to make sure that age factor has not increased the risk of an abnormal baby. All this has to be done. There is a lot of work, but I won't rule it out because, like I said, we have just had somebody conceive. So, but it's very, very individual.
Yeah. A couple of questions on vitamins. One is, what are the normal levels that you would look at for D3 and B12? And the second is that doctors seem to be saying that, all Indians are low on vitamin D3, so don't really bother. Is that true?
Wow. That's like saying all Indians are poor, so don't really bother. It's just idiotic. I'm sorry to say, so it makes no sense. Study after study tells us that having optimal levels of D3 has body-wide benefits. And then to say that because the Indian population is generally low in D3, everybody should suffer from poor health. And I'm not taking Caucasian studies and applying it to Indians. You please Google Indians low level of D3 health. You will find enough studies that show you how having low levels of D3 as an Indian leads to worse health outcomes than to somebody who has sufficient. So that's the simple answer on that. What levels do we look for? We are in preventive health. We are not just in avoiding disease. So for us to make you vibrant, healthy, we try and maintain levels between 60 to 75 Ng per ml. That is, so because it's reported in 2 units, NMOL per L, you need 2.5 times of that. So if you're looking at Ng per ml, 60 to 75 is our optimal range for D3. For vitamin B12, Pg per ml is the units it's reported in. We look for 600 to 950 Pg per ml of B12 as optimal levels.
Thanks, Mahesh. The next question is, what are the chances of getting pregnant naturally with retroverted uterus?
Again, we have had enough women with retroverted uterus who fall pregnant. It's a very, very common finding. As long as there isn't an additional complication of a fixed pelvic floor. If there is, what is a retroverted uterus? Again, so let's, quickly look at the diagram, because again, very easy to understand when we see images. So let's see this particular uterus, you can see, is facing downward. When a uterus is facing not downward, but slightly tilted upward, that is a retroverted uterus. So yes, it does lead to some complications, but it does not prevent pregnancy. Again, you can look at all the studies. Retroverted uterus does not seem to have a significant impact on falling pregnant naturally. That said, if the pelvic floor, the under part of this, is also fixed, there are some women who come with a retroverted uterus plus a fixed pelvic floor. That can indeed lead to some problems with carrying a pregnancy to term. Even then, falling pregnant is usually not a problem. But as the baby grows, because the pelvis is facing upward and it is fixed, the baby doesn't get enough space to grow. So that would be the condition I would worry about. Unless it's a very high retroversion, not really stands in the way of natural conception.
Got it. Is there any treatment for vaginismus?
Yes, there is vaginismus that, there is enough and more treatment. Even your gynecologist should be able to help you. Ayurveda, homeopathy, everything has, treatments for vaginismus, which is basically vaginal pain that happens. I suspect the questioner is asking during intercourse. Certainly, many times, something as simple as giving magnesium helps the muscles of the vagina relax and the pain is no longer there. But usually vaginismus can have a deeper structural issue. So it's good to see a gynac and see if there's any structural problem. Is there a smaller opening due to which you're facing the pain? Is there vaginal dryness? Vaginal dryness again can be corrected both with lubricants and with sufficient work that improves estrogen levels. So all possible. It's very, very treatable. You must seek help. Sometimes even an infection could be there and something as simple as an antibiotic could fix it for you.
Right. I finally come to our last question. Can one improve AMH and antral follicular count? If so, how?
Okay, so AMH, according to me, is a test that has got more limelight than it deserves in the last 8 or 10 years. AMH has become like a big, sword that hangs over every aging woman's head. AMH does not need to improve for you to fall pregnant. That is my simple answer. Can AMH improve? I have seen it improve. In fact, I've seen it improve by doing nothing. Instead of testing on day whatever you tested at random, if you test on day 3, your AMH may improve by, say, 50 basis points. So if your AMH was 1 when you did a test on a random day, test on a day 2 or day 3, that itself may improve your AMH to 1.5. So what is the relevance of this test? I often feel there is too much store that is put into the AMH. AMH is only relevant in an IVF scenario, and having a decent AMH is what will ensure better IVF success. So we don't work with trying to improve AMH, we work with improving fertility. So the second part of the question, antral follicle count is indeed crucial to fertility, but even that is not the 100% marker you should be chasing. For natural fertility, all you need is for one follicle to reach a size of 18 to 22 mm, for it to rupture and for it to release a normal egg. How many small antral follicles were there so that from that one dominant follicle could be created is often immaterial. Even from just 5 antral follicles, if they are of good quality, if the foundations are good, we have seen dominant follicles of 18 millimeters emerge in a period cycle. You can go on to have timed intercourse after that and conceive. So it's not that even antral follicle count has to be improved, but if you want to improve something between AMH and AFC, focus on the AFC. Focus on antral follicle count improving. As ovarian health improves, antral follicle count can improve, and that is a good sign. But don't chase AMH. It's not a good number to chase to improve.
Okay, one last question. She says, during intercourse, I suffer a lot of pain because of dryness. Is this affecting my chances of conception? She's worried that the sperm is not going inside. She also gets itching in the vagina and pain after intercourse.
Yeah, all of this is telling me that, there's possibly a likely infection, and there is a possibility of a low estrogen in her body in general. It is important for her to get a clinical, opinion, a proper clinical opinion. So please see a doctor, have the, vaginal area examined. The doctor may need to do a little bit of tests to understand why. But yeah, it is possible that with an extremely dry vagina, that the sperm, even if it enters, doesn't have any fluid that will help it to travel inward. And, it is possible for the sperm, lot of the sperm to also get deposited on the outer surface of the vagina, the labia and so on, and not even enter. So it's an important test for her to visit a gynec and get this corrected.
FSH value of 16 in men, Mahesh, does it mean a testicle growth issue? And how can we normalize this?
No, it also depends upon the LH. So, FSH is not that relevant for a man as it is for LH. If along with that, we also have smaller than usual testes, only then can we say that there is some problem with the gonads. Again, needs a urologist. In men, I rely a lot more on a physical examination than on chemical tests alone. In a lady, because there are so many hormones in play, biochemistry is a good way to examine a lady. But in a man, if you've got gonadal issues, please see a urologist, get a physical examination done.
There's a young lady who says she's 31 years old, and she says, I'm hearing so many stories of struggles with conception that should I even be, looking at egg freezing as an option? Because she doesn't know when she's going to be planning for a baby.
Yeah, so we do run an egg freezing support program as well at Sepalika. We do this because obviously we support the choice of anybody who feels that they haven't yet found a life partner, or even if they have, they're not ready to start a family yet. So should they be freezing eggs? The answer is yes, you can certainly have an advantage, especially if you haven't found a life partner, that if you freeze eggs at an early age, even 31, egg quality in Indian women at least begins to decline a little. But yes, it is possible to freeze eggs, and freezing eggs is a good way to ensure that even if you get married and want to start a family at 35, your eggs are actually only showing the youth of a 31-year-old. And again, if you optimize your foundations before you do the egg retrieval, your egg quality may come down. It may improve even more, and your biological age may be that of a 28-year-old before you get the eggs harvested.
Yeah. Thank you so much to everybody here for attending this session.